Welcome everybody, and we will today have interesting presentations and I hope discussions concerning a tricky phenomenon, macular edema. As defined by Ascaso and al., macular edema is defined as an accumulation of either extracellular or intracellular fluid in the central part of the retina. We can find multiple causes to the development of macular edema, including, of course, epiretinal membranes, diabetes, retinal vein occlusions, etc., etc. If we understand many causes of macular edema formation in diabetes like hyperglycemia, hypoxia, disruption of the blood-retinal barrier, activation of VEGF, increased vascular permeabilities, the mechanism underlying macular edema formation in retinal vein occlusions are even more obscure, and it becomes even more complicated when introducing the concept of inflammatory mediators, either in vascular pathologies like diabetes, retinal vein occlusions, or in pure inflammation like the posterior uveitis. When approaching the place of treatments in macular edema, we encounter many controversies, either because of poor statistical lengths, of poor study designs, or just because of too small samples. Who feel comfortable in front of macular edema, whatever the cause is? When we find many guidelines in the literature proposing different treatment options. As an example, N.R. Stefansson proposed different treatment options, but leave an important place for vitrectomy in the management of diabetic macular edema. Whereas this Spanish group only consider vitrectomy in the traction group and when there is already a functional loss. But isn't it too late? And as a third example, this Chinese group only consider vitrectomy when they encounter a tractional retinal detachment or when everything else has already been tried, anti-VEGF steroids. But who is right? I frequently feel like this green velvet monkey when trying to figure out the best treatment option to cure a patient suffering from macular edema, whatever the cause is. First of all, how vitrectomy is acting on retinal pathologies. N.R. Stefansson tried to demonstrate the effectiveness of vitrectomy. As observed on the left part, the vitreous is acting as a reservoir to retain and limit diffusion of various molecules, being beneficial or deleterious to the retina. As a contrary, in vitrectomized eyes, molecules are widely diffusing in the vitreous cavity. This explains why, as you can find on the lower graph, oxygen tension was almost normal in vitrectomized eyes that were suffering from branch retinal vein occlusion. But please, dig a bit further. David Bates is a very interesting person to follow in the literature, and he demonstrated that numerous isoforms of VEGF-A are present as regulators of its biological activity. But these isoforms are equally downregulated by our anti-VEGF injections. The question is, aren't we targeting too widely with anti-VEGF injections? And as you can see in the right part, Epping-Su demonstrated that sustained VEGF neutralization induce retinal neurodegeneration and vascular damage in diabetic mice. But who said that the injection concentration is the appropriate one in the eyeball? Please have a look on the volume between a 20 millimeter long eye and a 26 millimeter one. It's 2.3-fold higher. Who between us are measuring the axial length before injecting? Of course, nobody. To remember, in our 2012 EVRS study, we collected 2,600 macular edema cases. It is the biggest study realized to date, and we compared every different kind of treatment to each other. However, this study had numerous weaknesses, being a retrospective study with numerous etiologies, with many treatment complexities, etc. But it is a true representation of our life. How many of you try a first treatment, switch to a second one, come back to the first treatment, observe some resistance, thus try a third treatment? Yes, it is our real life. And if we move from one treatment to another one, it is definitely because we are not comfortable with current guidelines found in the literature. However, even if we observe some strong criticisms to our study, we observe comparable results in our anti-VEGF group to the RIDE and RISE study or to the RESOLVE study. In our macular edema study, when comparing vitrectomy to anti-VEGF or triamcinolone alone, we observed some interesting results. Everybody knows that epiretinal membrane is treated by macular peeling, but look at the results of retinal vein occlusion and diabetic macular edema in red. Probably that vitrectomy has been underestimated in our treatment options. Of course, who would dare to say that other treatments need to be thrown to the bin? Nobody. But the take-home message of this introduction is to say that we do not understand very well the pathophysiology of macular edema. So now please listen to our drivers. What is their practice? How do they behave in front of a macular edema, and why? Let the race start. Agnieszka, you make a clear distinction between tractional and non-tractional diabetic macular edema. What is your leitmotiv, please?
How do I switch? Is switch on? Okay. Thank you very much. And actually, the point is that I would like, during my talk, I would like to emphasize that there is no much of a difference between tractional and non-tractional diabetic macular edema from the perspective of pathology. Talking about treatment, I think it's very important to know the pathology that we are dealing with, because only by understanding what's going on in the eye, we are able to give the proper treatment. So if we ask somebody what is the main cause of diabetic macular edema and diabetic retinopathy, everybody would say that this is vessel leakage and non-perfusion, and this is quite obvious. And everybody knows that, but this gives just two-dimensional understanding of diabetic retinopathy. To dig to dig a little bit further, we need to look at the eye with retinopathy as the three-dimensional structure. And we need to understand that changes occur in all elements. Changes occur in vitreous, in ILM, and in retina. This is not just the vasculature that is sick during the retinopathy. Why traction and no traction question is so important? Because for some reason in literature, when you start finding the way of treatment of diabetic macular edema, you will find publications saying that if traction is present, you are allowed to perform vitrectomy. But when you do not have any traction, vitrectomy is kind of even forbidden, and only injection are the proper treatment. So my question would be, what is traction? Is traction a real force that is between tissues, or is traction something that can be seen on examination? Because if traction is something that we see on examination, this is closely connected to the resolution of the machine that we are using, of course. So 10 years ago, we would never say that the picture on right is tractional, because we did not have any tools to detect that. And now with new machine, we are able to do that. We have another tool to have a closer look to the diabetic macular edema. And here I would like to show you the movie from the surgery done in diabetic macular edema without any traction. You can see like it's very difficult to obtain the posterior vitreous detachment, and I need to fight with the vitreous, and I'm pulling it very hardly. I used a little bit of too much of a blue dye, but you can see that this dye is pulling in front of the retina. So my question would be, is it tractional or is it not tractional in this case? And definitely in this case, there was no preretinal tissue at all. Another observation that was made during the vitrectomy was retinal perfusion. And this is the same eye, and on the left side, you have the moment that there is no PVD performed yet, and on the left side, on the right side, this is the same eye after PVD is performed, and you can observe how vessels behave differently. They pulsate when there is no PVD, and they do not pulsate. They behave, the flow is regular when the PVD is done. That means that a touched vitreous does something to the vasculature. So the question is, what is the pathology of diabetic macular edema and retinopathy in general? And I would like to start not from the vasculature, which is obviously understood. I would like to start from the other part of the eye, which is vitreous. We know from diabetic study that hyperglycemia induces lots of changes within the body. And you know that changes in arteries are very common, and diabetic patients have strokes, heart attacks, and so on and so on. And they have this because hyperglycemia induce non-enzymatic glycation and cross-linking of collagen fibers. And these collagen fibers are exactly the same fibers like in the vitreous. So the vitreous in diabetic patient is changed. It got cross-linking, and the cross-linking changed the mechanical property of the vitreous. And the vitreous is no more like a normal vitreous, it's more like a glue, that is something inside the eye that's changed the property of the inside of the eye. Because the structure is changed, very often hyaluronic acid gets separate from the rest of the collagen fibers, and we have some sort of pocket that is formatted more to the back of the eye. That causes ascites to occur very often. So there is no such a thing, I guess, as posterior vitreous detachment in diabetic patients. There is more ascites, and even if we create PVD during the vitrectomy, we can kind of unroof the top of the cyst, but on the ILM we still have some collagen left. Why it is important? It might be important because of the traction that could be put to those structures. ILM is also changed in diabetic patients, and on the photography in the top you can see the ILM peeled in macular hole case. In the bottom picture, you can see the ILM peeled in diabetic patients, and the ILM is thicker in diabetic patients, that is for sure. And what can we see? They are cells, and those cells are mainly on fibrotic origin, fibroblasts. Okay. Gandalf performed a very interesting study when he, during vitrectomy, was checking the findings on ILM and in the vitreous. So he came to the conclusion that ascites is the hallmark of changes in diabetic patients, and they are cells on ILM from the vitreal side. And he came to the conclusion that even when no obvious traction is present within the eye, the vitrectomy can help with resolution of diabetic macular edema. And this is the result of one of his patients, and you can see on the top picture that there is a edema. On the bottom picture, there is no edema in macular region after vitrectomy, and those two pictures in the middle, they show cells that they were located on the ILM. So coming back to my scheme, in diabetic patients we have changed vitreous that is much gluish. We might have a pocket of liquefied vitreous somewhere in the middle. We can have thick ILM, and ILM, we need to remember that ILM serves as the scaffold for cells proliferation, and in the same time ILM is the barrier of water flow. And in regular conditions, here in the apex of Muler cells, there is aquaporin situated, and this aquaporin helps water come from the retina to the vitreous. When the ILM is very thick, the flow of the water from the retina to the vitreous is very changed. During the time those changes progress, we can see more and more cells, and those cells are, as I said, fibrocyte. They are also astrocyte and macrophages. They secrete VEGF. They can secrete inflammatory particles which are trapped within the vitreous and stay in front of the retina, and they may exaggerate the edematous changes within the retina. If this process is not stopped, the changes are more and more profound, and I do believe that at some point they start being visible because they are so profound and so big that this allows morphological changes to occur, not only on cellular level, but also at the more visible level. And I think this is the moment we start calling this tractional, because we can see the changes within the eye. Very important is the behavior of Muler cells, because they are actually responsible for keeping retina together, say it simply. They serve together with photoreceptors and the vasculature bed. They are some kind of retinal neurovascular units, and they prevent photoreceptor from dying. They have forces to repair retina, but during the time when diabetes and diabetic macular edema is present within the eye, those forces of Muler cells are getting weaker and weaker and weaker. They are not able to restore retina anymore, and that's why the edema is more and more profound and persists.
Thank you, Agnieszka. Sengul, on your side, you investigated the importance of macular and peripheral ischemia in diabetic macular edema. Please show us your interesting results.
Thank you, Philippe. We know that most of the eyes with diabetic macular edema has some capillary non-perfusion, either in macula or in the peripheral retina. But we don't know exactly the effect of this ischemia on diabetic macular edema, either macular ischemia or the peripheral ischemia. So theoretically, our hypothesis was that macular ischemia causes more edema and more photoreceptor damage, and this will decrease the visual acuity. And for peripheral ischemia, the peripheral ischemia, ischemic retina stimulates more VEGF, and this VEGF will cause more macular edema and will cause visual decrease. But this was theoretical, and we have some data in the literature, and some of this data is showing that patients with retinal ischemia had almost 4 times increased odds of having diabetic macular edema as compared with those without retinal ischemia. And this was done with ultraviolet with fluorescein angiography guided laser. And there are papers favoring this finding, like Takamura et al. Study, and they have shown that the addition of photocoagulation to ischemic areas prevent recurrence of diabetic macular edema after intravitreal bevacizumab injections. However, there are also papers against this, There is a very recent paper which was presented in AAO last year in Las Vegas, and that was a prospective randomized controlled study, and they used also ultra-wide field angiography guided targeted retinal photocoagulation in addition to intravitreal anti-VEGF to treat macular edema, but they found no additional effect of this laser for treatment of macular edema. So we have some conflicting results. And also, we have relate study, and this trial, although this was on retinal vein occlusions, not on diabetic macular edema, but gives some idea to us, I think. They have studied the addition of peripheral laser ablation to ranibizumab to control macular edema in vein occlusions, and they have find out that it didn't decrease the number of injections, it didn't give better visual acuity results. So we have these conflicting results with the literature. We planned a retrospective study in 259 eyes of diabetic macular edema patients, and we graded the degree of macular ischemia and peripheral retinal ischemia in fluorescein angiography, and central foveal thickness and structural changes of retinal layers were also detected, noted in OCT. The degree of macular ischemia was graded like that. We divided the foveal avascular zone into 4, and if there was macular capillary non-perfusion in just two areas, then that was graded as mild, and if it was more than 2, it was graded as severe. And for peripheral retinal ischemia, if there was less than 5 disc diameter area of ischemia, it was mild, and if it was more than 5 disc area, it was graded as severe. You see a mild macular ischemia in the left one, and a severe one in the right picture. So we had macular ischemia in 115 eyes, almost 45% of the eyes, and 2/3 of them were mild macular ischemia, and 1/3 were severe macular ischemia. And as you see here, the macular ischemia was a bit more prevalent in eyes with proliferative diabetic retinopathy as expected, but this was not statistically significant. But peripheral retinal ischemia was much more prevalent in PDR cases, which was also expected. And coming to the functional results, visual acuity was much less in eyes with severe macular ischemia, and this was statistically significant. And central foveal thickness was also higher in eyes with severe macular ischemia, and there was more outer retinal damage in OCT, and in severe macular ischemia cases, this was also an expected finding. Coming to the peripheral retinal ischemia, we have found out that 77% of the eyes were having some ischemia, and you can see mild peripheral retinal ischemia in the left picture, and severe peripheral ischemia in the right area. And almost half of the eyes with peripheral ischemia had mild, and the other half had severe peripheral ischemia. And as you see here, the visual acuity was not so significantly different in between the severe peripheral ischemic eyes and mild or no peripheral ischemic eyes. That was interesting to me, and also central foveal thickness was not so significantly different in between these groups with severe, mild, or no peripheral ischemic eyes. Actually, I was expecting to find more central foveal thickness measurements in eyes with severe peripheral retinal ischemia. Although it was a bit more, but this was not statistically significant. So, in conclusion, the presence of macular ischemia is a poor visual prognostic sign in eyes with diabetic macular edema, which means that if you have more ischemia, it means it will cause more edema and more damage. And the presence of peripheral retinal ischemia does not seem to have an effect on the severity of macular edema and visual prognosis in diabetic macular edema. Thank you.
Thank you, Single. Ivan, you have your own protocol of treatment concerning the CRVO that is mostly based on the venous pressure. Please show us.
Good morning, everybody. Thank you very much for the opportunity to share with you our experience. The main problem with the occlusions for the patient, of course, is visual acuity. The main players here are persistent macular edema, parafoveal capillary non-perfusion or reduced perfusion, damage of the retinal elements and RP due to intraretinal hemorrhage. And what we know from our experience is that only macular edema is potentially able to be modified. Retinal damage by the increased venous pressure. Everybody knows the signs of edematous CRVO and tortuous venous with increased diameters. So hydrostatic pressure is over 20, and that's published data. And that's damaged the inner barrier, producing of the VEGF and other inflammatory mediators, macrophage cell activity, and what are the sequences of the persistent venous pressure elevation, and what we can do about it. On the market, we have several options, pass-plan vitrectomy plus or without ILM, intravitreal traps, laser-induced chorioretinal anastomosis, or combination one step or consequent steps. Let's see one by one. Pass-planar alone. I absolutely agree with the tractional or non-tractional idea of the Agnieszka with small comment. It's very difficult sometimes to say, oh, it's mostly tractional. No, it's not tractional, or combination. But the real truth is that when we go to schema, not from Sebak, and from Jan Wors, who died recently, it's a bursa premacularis. And this bursa trap all the mediators there, and these mediators are mostly upregulated. So that's a vicious circle. And if you remember well your PVD, that's come with a lot of things with the pressure also. And that's changed not only ex vacuo, the change of diameters. It's a question of to release all that things. And okay, one more thing. You can use only RTP or to cannulate the veins as well, put some concentration of plasminogen activator, or to do a run. With peelings, that's remove the traction in the scaffold for proliferating. That's remove the inner retina and decompress the edematous retina. And of course, the gliotic response release extracellular fluid to the vitreous cavity. What about traps? That's, of course, inhibit all the interleukins participating in a process, inhibit VEGF, some other factors, reduce vasculature permeability because of the endothelial fenestration. And one more option, coming from Australia, of course. Everybody knows the McAllister techniques, and everybody thinks that's work only in Australia. But that is the only one way to reduce elevated hydrostatic pressure and improve the retinal flow. So, one more thing, hydrostatic pressure over 20. Let's have a closer look to one typical example. Look here, you can clearly observe after the incident the optociliary shunt. And when we create the lacra, the optociliary shunt, it's almost disappear. So that is the pretty physiological way to manage the things. Probably we don't know precisely what's happened here, and but it's clearly see here. And here is the lycra. I will show you the combination as well. You can combine it in one procedure at the time of pars-plana vitrectomy. Here you can see the two attempts of lycra, and look the sign of the tortuosity and the venous pressure here, and after 8 months, it's completely different. And let's see on a fluorescein angiography, you'll see here several laminar flows. So normally that's only laminar go to the optic nerve head, but when you have a potent anastomosis here, you will see several laminar flow going from the periphery to the anastomotic place. So one more time, to the anastomotic and going to choroid. So several more examples. We did that at 2013, Demeter's CRVO and the lycra 1 year after, and several years after. The image is blurred because it's a cataract. It's only on a slit lamp technique without combination. And how to choose? I am very influenced by all the techniques on the market, of course, but I know that clear observation, even in glaucoma case, I already stopped to see the numbers from NFLs and etc. examination. I always see the vasa vasorum, the optic nerve head, and now I use only my digit to press during the indirect observation of the optic nerve head, and when the pressure is normally shows the stop of the vein, that's a good one. When it's not possible to stop the vein, and minimal, it's absolutely react to my pressure, I said that's a good, when you got a good perfusion, I'm going to traps. When it's moderate, I'm going to lycra, pars-plana, hemodilution, going for the chematocrit for the results. And when I got the minimal, I combine lycra, pars-plana with some crystal triamcinolone. Thank you very much.
Thank you very much.